Okay, you can't draw air in through your nose because your air is moving in and out of your neck. They do have a drainage tube. Remember, we don't want any fluid to build up around that suture line, so we might put in a little JP, maybe a little rubber tube, something like that, to help with the drainage. Okay. Hopefully y'all got that. Risks. No risk of aspiration, so highlight that. So when you answer your questions, make sure you're reading what type of surgery they've had done. Because with a partial, they are at high risk for aspiration because we took the epiglottis out. But for a total laryngectomy, they no longer at risk for aspiration because we've sutured that airway off. They are an increased risk of bleeding. For tracheoesophageal fistula, because if they have some type of feeding tube, and then they have their tracheostomy tube, the tube can rub and cause some type of communication between the esophagus and the trachea. And then respiratory tract infection, because we've taken all of the humidification and the filtering system is completely gone now, because they're not breathing through their nose and mouth. So these folks would need pneumonia vaccines, flu vaccines. They're more susceptible now to certain things than they were before. Okay, so this is a picture showing you a total laryngectomy. Again, it shows you that usually there's one or two tracheal rings that are involved with it that come out. And then when they suture them back up, you can see that they're left with their stomal hole. They have a little drain coming out and then their suture line. Tracheostomy holes are a little wider in nature because the appliance that we put in is shorter and wider. So it creates a larger stomal hole than what a regular tracheostomy would make. Most of these folks down the road will not wear an appliance once this is well healed. Unlike a person with a tracheostomy, their laryngectomy tube is wider and shorter. And then once it's healed, many of the patients or clients do not wear the appliance like they do for a regular tracheostomy. This is a picture of a person before a total laryngectomy and then afterwards. So in the first picture on your left, you can see how the air is moving in and out of the nose and mouth and down into the trachea and to the lungs. On the right-hand side, you will see that the air is entering the mouth, in the nose, and down the esophagus partially, or maybe fully, but it is not for air exchange. There's no CO2 oxygen diffusion taking place. That only is occurring via the tracheostomy or the laryngectomy. Here's your pharyngeal space. This is all sutured off. Now, if your patient has a NG tube down their esophagus to keep their stomach from expanding or blowing up or having any issues, you will not be touching that. If it comes out, you will leave it out, because if you go to put that new NG tube down and somehow you're pounding it on the surgical site, you could disrupt that. So you have a patient with a total laryngectomy, comes back with an NG tube. It often has some type of tape to it that says, do not reposition, do not move. Because we don't want it to break open that pharyngeal space that's been sutured shut. And hopefully that makes sense to you with that. But it would be a safety issue. We don't want to cause them any harm. So we want to make sure we're not moving that or adjusting that gastric tube, if they have one. Okay, we've got two more. So number 6 is a radical neck dissection. This is that we remove the soft and subcutaneous tissue. We also remove the sternocleidomastoid muscle, plus others, the jugular vein, and the spinal accessory nerve. So when you read in any books about a radical neck dissection, I want you to know that a radical neck can be done for any head or neck cancer. It doesn't have to just be laryngeal cancer. So I could have tongue cancer, jaw cancer, and I might still need to have a radical neck dissection because I'm getting rid of lymphatic area. Okay, it's involved more tissue than that. What are some of my issues? Shoulder droop, because if I do my spinal accessory nerve, that allows you to shrug your shoulders. If that has been severed or removed, you will not be able to shrug a shoulder. It'll droop. I'm going to have some drains in place, and I might end up having a graft. If they've taken out quite a bit of tissue around my neck area, I might have to have a graft from my chest. They'll take tissue from your chest, and I'll show you that graft here in a minute. So I would have a total laryngectomy, but my diagnostic studies show that I have involvement to other areas of my neck. So I would have a total laryngectomy plus a radical neck resection. So I would take out what I needed for my total, but in addition, I would also have these things removed. Okay. Oh, one more. And we'll talk about the graft. If they actually do grafting, if you've ever seen skin grafts or anything like that, remember you have a donor site and you have a grafting site. So you'll have two places that you'll need to check on. Okay? Wherever the donor tissue came from and wherever the donor tissue went, you'll have to keep an eye on both of those areas. The last one is number 7. Oh, risks of the radical. Airway obstruction from swelling. Carotid artery rupture, especially if we don't put a grafting material back in because you've exposed and removed so much tissue, the artery is more exposed. And then if you do donor tissue, there is always the risk that your tissue will not take, meaning your new skin or your new piece of muscle turns black and does not acquire any new blood circulation and therefore is essentially dead. And it will have to be removed. Okay, so airway obstruction, carotid artery rupture, and skin flap necrosis. In the radical neck, you can see that we pretty much are going from the clavicles to underneath the jawline. That's how much they need to open the neck up to get to all of these areas. So it's a pretty extensive surgery for folks. Now on this particular one, all they've done is a radical neck. You can see there's no stomal hole. So this has been probably done for some other type of neck or head cancer. Here's a picture of our flap, our muscle flap, our tissue flap. We're taking pectoralis muscle, and we're taking it from the chest there, and we're moving it up to the neck. So now you have your graft down at the bottom area. So that's what we would be watching to make sure that it has good circulation, that it blanches, all of the things that we want it to do. Then we would also be watching our incision here on the chest where we took our graft from. So we would have a surgical incision there also. And hopefully the area that we took it from would all be doing well. Our grafting area is the place that we would be watching very closely. Okay, our last one, number 7, is a modified radical neck resection. And the only thing that we remove here are lymph nodes. Okay, so the only extra thing in a modified radical neck that gets removed are lymph nodes. So unless somebody told you that you had a modified radical neck resection, if you were having it with a total laryngectomy, you probably would never know it because the only additional thing are lymph nodes. So that one's pretty easy. No additional risks with it except the typical post-op. You know, you're obviously going to have an incision where they opened your neck up, but there's no extra complications associated with it. Okay, preoperative then, when you have somebody that's coming in for a laryngectomy, this is probably going to be in maybe your office, surgeon's office, maybe in a pre-op holding area. Of course, we don't bring patients in like we used to years ago, a day before the surgery, even 2 days before the surgery, and do anything with them. So a lot of this is going to have to be done in the office or in the preoperative area.
Could you please go back to that last slide just for a second? Okay.
All right.
Thank you.
You're welcome. So, talking about physical changes, support for all of family members, fear of losses that could be job, their ability to communicate, social relationships, their prognosis, and fear of rejection. Postoperatively expectations, they are going to have a laryngectomy tube. We talked about it being shorter and wider. The need for suctioning. When they suture off that pharyngeal airway, we really don't want them to do a lot of swallowing for 2 or 3 days because every time the throat moves up and down, it pulls on that suture line. So we want to teach them to suction their mouth and to expectorate secretions instead of swallowing them. So they're going to have some type of nasogastric tube or feeding tube. And then we teach them to deep breathe, but we really don't want them to do very much coughing. Again, it puts too much stress on that suture line. So laryngectomy tube, shorter and wider. They can have a Yonker suction, so they can suction their mouth out. Some type of feeding tube, avoid swallowing, and then deep breathing versus coughing. You want to assess their ability to see, hear, write, and read. Speech therapist, it would be great for them to go in and discuss with the speech therapist what type of alternative speech they were going to be thinking about, and they could possibly work on that prior to having their surgery. There are support groups like the New Voice Club or the Lost Chord Club that could be helpful to patients. Good oral care, no infected teeth, decreased risk of infection. We know the oral cavity is probably our biggest risk of infection that we have. So we want to make sure that we don't have infected teeth, anything that could interfere with the healing from their laryngectomy.
What was number 5 on the last slide for the post-op procedures and expectations? Okay, perfect. Thank you.
You're welcome. So our first possible problem could be ineffective airway, and how we're going to remedy that. It is a high priority for us to keep the airway clear. We're going to keep the head of the bed elevated, and we're going to suction as needed to keep it clear. So we would go and follow the same skill sheet as what we did for our tracheostomy lab. This doesn't change. Deep breathing, turning Q2 hours. Once they are okay to cough, they can do a diaphragmatic cough, and I have a picture of that in just a couple more slides that I'll show you. Number 5, we want to avoid medications that suppress the respiratory system. I have a couple listed out. Really, it's just opioids, but I do want you to know if you had this kind of surgery done, you are going to need some type of narcotic in the first couple of days. We still do want you to take deep breaths. We want you to move around for us, and you're probably not going to be able to do that very well without some type of narcotic on board. However, once we can tolerate and go to some type of Tylenol, we probably will make the switch. Watch for signs and symptoms of decreased oxygenation. So we can do that through a pulse oximetry, their vital signs, and then arterial blood gases. Encourage activity, especially as they can tolerate. Encourage participation in self-care. We already talked about they will experience a lot of losses post-surgery, so everything that they can see that they can still do for themselves would be a positive thing for them. And number 8, humidification. Decreases cough, crustation, but be very careful with extra moisture. And I think this is where, just looking here at the notes. So, no, I get to it later on. Okay, I won't discuss it yet. All right, so that's all for ineffective airway then. Here's your diaphragmatic coughing. They actually lean over. If he keeps his stoma at the lung level, he's able to expel the secretions a lot easier. Make sure they have something there that they can cough into, because it can be a little embarrassing for that to happen, but it does help them expectorate their excretions or cough them up a lot easier if they can get the stoma down to the lung level instead of the mucus having to come upward. Okay, our next one is a risk for bleeding. We want to observe for bleeding. If they have a Jackson Pratt, remember, keep it compressed. That's the only way that it does drain, is when it's compressed. If it's fully expanded and looks like a hand grenade, it's no longer draining. Watch their vital signs. There is a potential for carotid rupture arteries from their radiation, so you want to assess for rapid swelling of their neck. Bleeding and pulsations at the site. A change in color, and they will complain of sternal or high epigastric stress, almost like they have indigestion or pressure up in their sternal area. The action for this is to apply continuous direct pressure, summon assistance, and prepare for an emergency surgery, and then provide good emotional support for them. Okay, take a 5-minute break because I need to use the restroom, and I will be right back, okay?